Good morning. Thank you all for coming, and I do hope and pray that this gives you some information that will be helpful to all of you. I thoroughly enjoy questions, so if at the end there's more questions that you have that I have not covered or considered, just holler, please. I'll give you a quick background of myself since I am new to the area. I basically started out my career as an exercise physiologist and decided to go on to prevention, learn about biomechanics and movement of the body. So I went and got my doctorate in physical therapy. I had a practice in Cleveland, Ohio for a couple years, and I had it burdened on my mind that I wasn't done with school, so I decided to go back to medical school and really felt led to be an orthopedic surgeon and just fell in love with the hand. So I've dragged my wife around to our honeymoon was a clinical rotation for physical therapy school, so I still owe her after 15 years of all the schooling and hard work that she's done for our family. So let's get started. We'll talk about carpal tunnel syndrome. It's one of the most common things that I see in practice, and it can be quite a nuisance to many people, as some of you in here may very well be experiencing or have experienced. If you can't hear me, please just holler at me, okay? Can you hear me okay right now? Yeah. Okay, very good. Okay. So this morning, we're going to cover just some basic pathology and anatomy, the symptoms, examination that you would experience should you come in and see me, treatment options, and then we'll go over some questions that may not have been covered. Carpal tunnel consists of, right in our wrist, literally something that's formed like a tunnel. That's why it's called the carpal tunnel. And right here, these are going to be our wrist bones. And over top, there's going to be this ligament. And that's called the transverse carpal ligament. And that, formed with the bones, actually forms the tunnel. And in that tunnel, you have 9 tendons. And the 9 tendons, there's 4 right here at the back of the arm. Those are your flexor digitorum profundus. Don't worry about the names. And then you have your flexor digitorum superficialis tendons. And these are the 8 tendons that move all of your fingers. The other tendon that's in this tunnel, as I'm circling right here, is going to be your flexor pollicis longus. Pollicis stands for thumb, so this is the tendon that flexes the thumb. And the nerve that causes the problem during carpal tunnel syndrome is your carpal tunnel, is the median nerve, this thick yellow nerve here. And on dissection, it's very thick and can get very well irritated. And the irritation can happen, as we'll discuss throughout the remainder of the slides, from some inflammation of these tendons, from overactivity or overuse, which causes increased compression inside that tunnel, and can cause this nerve to actually be compressed. And it's called a compression neuropathy. And what actually happens as we compress that nerve, it actually decreases the blood flow to that nerve locally where it's being compressed. Every nerve in our body has its own tiny, tiny blood supply. And it's very tenuous, and it doesn't do well with compression. So when it gets compressed, the nerve responds by giving you that numbness and tingling feeling initially. Later on is weakness and atrophy or decreased size of the muscle. So as we were just discussing, it's the compression of the median nerve in that carpal tunnel, and it's the most common compression neuropathy. So this is a larger picture of the structures that we were just discussing. And again, here's your median nerve coming right down the center. And these 4 tendons here are the ones that bend your fingers like this, okay? And the actual layout, if you're curious at all, is that these 2 tendons on top, if you were to cross your middle and ring finger like this, turn it over, put your pinky and your index finger behind it, that's how those tendons sit in that carpal tunnel. And then right over top of that is going your median nerve. And over the top of that median nerve is this thick ligament, the transverse carpal ligament that we mentioned prior. I'm going to stop here. Any questions thus far, just of the basic concept of the structure that we're talking about? So basically you have wrist bones and a ligament that make up a tunnel. The tunnel has a nerve and has tendons. That nerve gets irritated. So acute carpal tunnel can happen by trauma, or we were talking about pregnancy just a little while ago. And when it happens during pregnancy, it often happens on both hands. And that is usually resolved once pregnancy is over and the swelling and edema goes down. Chronic carpal tunnel, which we see the most of, can be caused by diabetes, or rather people who are diabetic have an increased rate of having carpal tunnel syndrome. Hypothyroidism actually is a large contributor to carpal tunnel syndrome. That's why when you have medications such as Synthroid or levothyroxine, it's very crucial to keep up on that, not only for the thyroid issues throughout the rest of the body, but also can affect your nerves throughout the remainder of the system. Patients with rheumatoid arthritis, and sometimes you can get a cyst called a ganglion cyst, which we often see on the wrist, on the back of the wrist, or on the front of the wrist right around here. Sometimes, though, you can get a ganglion cyst inside the carpal tunnel, which actually compresses that nerve as well. And tenosynovitis, or the tendonitis, is a typical term, but tenosynovitis is more accurate. Every tendon that we've discussed has a little layer over it called tenosynovium, and that can get inflamed or irritated, and as that gets inflamed, it decreases the space in the carpal tunnel, and that decreased space in the tunnel irritates the nerve. And sometimes there's some random muscles called accessory muscles. There's the Ganser muscle. Very rare, but I've seen it a couple times, and it's quite fascinating, but nothing but academic, and it can be a problem in the carpal tunnel. Treatment is still the same. You'll often find it in people who use their hands, wrists frequently, such as assembly line workers, as you see here. And people in an office setting who are using the computer will tend to have it. Now, there's no necessary support that overuse or frequent use in the research is directly correlated to it, but that is so frequently what we see empirically, that it's a lot of overuse of flexing your wrist, moving your wrist, picking up things, that is what can contribute to, not cause, but significantly contribute to the formation of carpal tunnel syndrome. That's why if you're on a computer, they sell all those pads that you can rest your wrists on. Everybody talks about ergonomic chairs or posture. All that does come in to influence not only your carpal tunnel, but problems at the elbow and even problems at the neck or problems in your shoulders. So posture, which we all get harped on from day one, is significant for a lot of issues. Symptoms. Does anybody here wake up with numbness and tingling in their hands in the middle of the night? Has anybody experienced that? Where you wake up, okay, and you have to shake it out, and it's really a nuisance, and you go back to sleep an hour later, you wake up, and you're shaking it out again. It seems to give you that relief. Okay, that is one of the primary symptoms that we hear that people come, it's one of the main things people come in for. I just can't sleep. They end up having numbness and tingling for a while, but once it starts waking them up, we all don't like to be woken up, and you don't sleep well, and then it actually gets worse. So numbness, tingling, and you can even have itching in your fingers and hand. And the primary spot that we tend to see it, and this is the typical, is on your thumb, index, middle finger, and just this little half, the thumb side of your ring finger. That is the typical presentation of the numbness and tingling or paresthesias in the hand from carpal tunnel syndrome. The itching is a response to the nerve as well to irritation. So if you have itching in those fingers, it can be contributed to by the carpal tunnel syndrome. And what we often hear, patients will come in and they'll say, my hand is always swollen. Look, can't you see the swelling? No, I don't see any swelling. And it's not necessarily swollen, but that is the sensation that is given by those nerves from the compression on the median nerve. So you do feel like it's swollen, and it really feels like you can't get a glove on at times. It feels irritating, but when we look at it, if we take measurements, it's usually not swollen, but it's a real symptom. And as we discussed a little while ago, it wakes most people up, and it causes them to shake out their hands and wake up their partner in bed often, and that can be a nuisance to everybody. And then, as it gets worse, the symptoms become more frequent during the day. So typically they start at night, and the reason it starts at night, I think I have a picture here. I don't. Typically it starts at night because we all sleep in the fetal position. We all end up flexing our wrists like this all night long. We don't realize it, we just do it. And when you put your wrist down like this, you're sleeping at night, you're comfortable, that's actually increasing pressure in your carpal tunnel. Enough to the point that it actually compresses that median nerve more. And so it causes that numbness and tingling. In the middle of the night, you wake up, you move your wrist back, you flick it around, and it kind of relieves that pressure on that median nerve. So we don't mean to do it, but we all do it, okay? As the chronicity progresses, you'll even notice changes in temperature and sensation other than just numbness and tingling. Sometimes you can feel cold or hot differently. Sometimes it will sweat. And And you also notice that you might begin to drop things. Now, dropping things can mean one of two things predominantly in the hand relative to two nerves. One, the median nerve that we've been discussing. Two, the ulnar nerve, which comes right around the elbow. So when it's carpal tunnel, and it's really been around for a long time, a lot of people just deal with the symptoms and say, I don't need this is fine, I can deal with this, it's just numb and tingling, I can deal with the waking up. But then what they start to see is what we call thenar atrophy, and the thenar refers to your thumb. And that thick muscle that we all have to be able to grip things actually gets smaller and gets weaker, because off of that median nerve that's going through your carpal tunnel is a branch from that nerve called the recurrent motor branch. It actually supplies the motor function to that thenar musculature, to that thumb muscle. So when you go to grab something, you don't have the strength that you once did, and you drop it. And a great example is, and this is one of the questions I'll ask patients when they come in the room, does it bother you when you get things out of the refrigerator, like a milk jug? And sometimes people say, yes, that really, I don't have the strength like I used to, and I have to take my other hand over and pick it up and then move it. That's often due to the weakness contributed to by the thumb muscle. I had mentioned also that there's the ulnar nerve that can be involved with weakness in the hand, and that contributes to the muscles between the fingers that actually also contribute to grip. But relative to your carpal tunnel, the median nerve causes the muscle of the thumbs to get smaller if it's being compressed on long enough. Other complaints that patients have, and this is something we'll often ask, do you have difficulty buttoning your bra, buttoning your shirt? And people often say, I've been stumbling around. I can't believe you just asked that. And that, again, is due to dexterity from your fingers, from the median nerve, not giving you the proper sensation. So you have that numbness and tingling, and then you go to touch your button, and you can't tell exactly where it is. You can't control it well enough. That is from the compression on the median nerve. Additionally, that can also be contributed to by your ulnar nerve, as we just discussed. And people also note it, we all talk on the phone, especially cell phones these days have become even more utilized significantly, and holding the phone up to your ear can bother people in both the ulnar nerve and the median nerve. And people, if anybody here uses a hair dryer, some people say it just gets really weak, tired. I have a tough time really even blow drying my hair anymore. And that's not atypical. And these are the common things, almost 8 out of 10, if not 9 out of 10 times most people report, especially the nighttime shaking out the hands. Any questions thus far? Okay. If anything pops up, we'll gather them at the end for sure, but I'll keep stopping and asking if anything is pertinent right now. So what I wanted to give you a sample of is what my typical routine is when a patient comes in with the complaints that we just discussed. If you were to come in and see me, the first thing when I immediately meet you, I shake your hand. I always enjoy shaking hands, and that's actually part of my evaluation. One, strength and your control. Two, I'm immediately looking at you with the eyes, but as I'm looking at you sitting down, I always have the patient sit down across from me, is I'm looking at your hand. From the very get-go, I ask you some questions, and I'm constantly looking at your hands. It's my job, and it's what I enjoy. And we'll look for signs of that thenar atrophy, okay, of that thumb musculature. I also will look at your elbow range of motion to tell me if there's any restrictions up at your elbow that could be contributing to the difficulties you may have down at your wrist. And I always have people make a full fist to see if they have function, and I'll always test your grip strength on a little dynamometer that we use. And I'll also look at how well your fingers open and close. All that is to test the median nerve and also the ulnar nerve. I always like to make sure that the ulnar nerve is not involved. Another test that we do is the Phelan's test, which is demonstrated up here with one hand. I have everybody do it with both hands concurrently. It's an uncomfortable position even for me, but I have you sit in this position while I'm talking to you for about 30 seconds to a minute. Should this reproduce your symptoms, that's indicative that the carpal tunnel is being tight or the nerve is being compressed upon. Thereafter, I take and do what's called a compression test or a Durkin's compression test. The reason it's called Durkin's is some physician came up with it and put his name on it. But the main thing is that it's a compression on the carpal tunnel. And this is an excellent photo showing where I push. And I will push after doing the Phelan's test. Same thing for 30 seconds to a minute to see if it makes the numbness and tingling worse or even if it were to produce numbness and tingling. And then we do what's called the Tunnels. The Tunnels was discovered by another physician who put his name on it. Everybody in the orthopedic world knows about it. And we literally just tap over the locations of the nerve. I do your wrist to look at the median nerve, and then I'll also do your elbow to look at your ulnar nerve, or the funny bone, if you will. If it reproduces symptoms in certain parts of the fingers, then that's also indicative of carpal tunnel or even the ulnar nerve being involved. Often I will see with carpal tunnel syndrome 2 additional pathologies or 2 additional things that people don't necessarily bring up because they're so distracted by the numbness and tingling. The first one being is what's called trigger finger. Has anybody ever here had or heard of trigger finger? Okay. So the individuals, patients fingers get caught down and they can't open up and they have to pop it open. That's often what's called a trigger finger. And so when you come to see me, I do a very quick assessment of that. And the easiest way to assess that is I push on an area where what's called an A1 pulley. Every finger has pulleys in it that allow us to bend our fingers biomechanically without the tendons bowstringing. It's all physics. God designed this hand and our whole body to be all revolving around physics. So what I do is I check that just to make sure that's not going on. And then I also look at folks' thumb. We call it the thumb CMC joint. It's at the base of your thumb. One of the most common procedures as well that I do is an arthroplasty to this joint. A tremendous area of arthritis and pain and decreased function for a lot of people. So a lot of people come in with carpal tunnel syndrome, and I will assess that region as well, because sometimes I can get you great relief for a good 3 months. Some people have responded for a good year just by one small corticosteroid injection into that thumb joint. And if it's going on concurrently with the carpal tunnel, and should we ever go to surgery for carpal tunnel, I can inject the thumb while we're in surgery so you don't even feel it one bit. And pertaining to the trigger fingers, that is easily treated often with 1 injection, sometimes 2 injections. If they don't work, it's a very quick procedure that lasts literally about 6 to 8 minutes in the operating room. But I always like to make sure everything's looked at. Those are the 2 most common concurrent presentations with carpal tunnel: trigger finger and thumb joint arthritis. Other tests that I do, Froment sign is something I look at for testing the ulnar nerve function again. I always look at the superficial sensation. And then also I do what's called 2-point discrimination. This will tell us the density of the nerves in the fingertip. All I do, everybody remember Bruce Lee or the old Kung Fu movies where they had those throwing stars? I use something that looks like a throwing star. And it actually has 2 little tips that spread out in marked millimeter distances. So it starts anywhere from 4 millimeters all the way up to 25 millimeters in distance. And I use that to assess how well a patient can discern between the touching of 2 points or the touching of 1 point. And that can be indicative of a chronic problem if there's any decrease in that ability to tell the difference between 2 points or 1 point. And as mentioned prior, I do use this dynamometer here to test strength of the grip. And then we also look at how well you can pinch with your thumb. And that's on this little machine here. Those literally take about a minute and 30 seconds to do both together. We're talking throughout it, constantly evaluating and trying to see if there's anything else that we need to look at and evaluate. I don't typically perform x-rays of carpal tunnel. The only reason I would perform the x-ray is if I would be concerned that there's something else contributing to the carpal tunnel syndrome. For instance, if there was a history of a fall, that I might be considering that there was an old fracture in one of the wrist bones. But really, it's very rare for me to perform x-rays for a carpal tunnel. So we went through all that, and I'm quite comfortable in discussing with the patient that you have signs very consistent with carpal tunnel syndrome, you have carpal tunnel syndrome. What we do to confirm that diagnosis is perform a test called electrical diagnostic testing, or broken down is electromyographic testing and nerve conduction velocity tests. Now, this is a test that we use to measure how well the muscles are functioning that are stimulated by that nerve, and also how well the nerve is, how fast the nerve is transmitting its information. And that can tell us, there's certain parameters that we look at, or cutoffs, that can tell us how compressed the nerve is. We can rate it as mild, moderate, or severe. And in severe cases, it's time to go right to surgery. In mild cases, we can try to treat with a splint, which I saw some folks on here. We can even try injections, and we can also try some occupational therapy that have their own techniques that can work very well. But the electrical diagnostic tests do give us great information and objectify everything. And they also give us a baseline for down the road, 10, 15 years, should there be a reproduction of symptoms that we can compare the two down the road, should there be any other issues that arise. The challenging aspect of the electrical diagnostic tests is that you can come in and present just right out of the book with carpal tunnel syndrome. All the tests are positive, all your complaints, everything is ringing so true of carpal tunnel syndrome. You go and have this electrical diagnostic test and it comes back normal. And how we deal with that is sometimes we'll repeat the test, but often we'll see how you progress over the next few weeks or so. But if you continue to present that you have carpal tunnel syndrome, I discuss it with you or the patient, and we proceed forward with the carpal tunnel release. If it is that clearly evident that you have carpal tunnel syndrome in the clinic, we need to proceed forward with taking care of it surgically. Again, if it's moderate or severe. Now, when you come into St. Francis, it's not just me. It's a team. It's a hand team, and that was a very big issue for me coming here. I didn't want to go somewhere and be the surgeon, never see the therapist, never talk to the therapist, which happens at a lot of places. And so when I came here and saw that the therapy department is right across the hallway, I was very pleased. And then I met the occupational therapists. And our occupational therapist, Gretchen, here, has 20 years of hand experience, and she has trained other hand therapists. And so to get your hand therapy certification, or what is called a CHT, certified hand therapist, it takes at least 5 years of experience and an extreme amount of hours under tutelage of another certified hand therapist. So our team of therapists is phenomenal. I communicate with them, I will walk across the hallway with them talking about patients. So we are always striving to be in constant contact, and they are excellent. Other part of our team will be surgical schedulers and the office scheduler and Michelle and Melissa and Kenyetta. They all work on part of the team that you would work with. So Michelle, you'll see in the room with me. She is tremendous medical assistant. She is one of the most pleasant individuals. I've only been here 2 weeks, and I've already told my wife they could not match me up with anybody more perfect than Michelle. So that's great. Melissa's very kind on the phone and scheduling office appointments, and Kenyetta's got a great sense of humor and a beautiful smile that talking to her on the phone, you can almost see it through the phone. So this is the hand team. And again, I want to emphasize that it's team. We just discussed what the team is. And then non-operative management. So if you come in with mild symptoms, or you just simply don't want to try surgery right now, the first thing we always try is splinting at night. And it's a splint that looks very similar to this. It's called a cock-up splint. It keeps you in a position where you're not able to flex down like this in the middle of the night. Sometimes we have to put them on both wrists if you have the symptoms both sides. They are cumbersome. They can be a nuisance, but the ability to sleep outweighs the nuisance that they can be. And if the symptoms have progressed well enough to during the day, we will have you wear it during the day. We also talk about activity modifications at work or at home or at hobbies or with kids. Sometimes we have to work on how you lift, on how you move, and that's all part of mechanics and posture. Some people do report benefits with 2 medications, or actually one's a supplement, a vitamin B6. There is some research supporting that does give benefit to people with any nerve condition. Some people do take that over the counter, and they do report benefit. Non-steroidal anti-inflammatory drugs such as ibuprofen can be helpful, but you definitely need to make sure you take that with food, as it does have a significant effect on your stomach. Some people do also take Tylenol. That's more an effect on your liver for metabolism, and they do get okay results. I never prescribe pain medication before surgery. If it is a moderate or even severe, depending on the patient, if they really are not trying to do surgery, I can do a corticosteroid injection into the carpal tunnel. It's quick. It's a total of 2 cc's, which is less than a teaspoon. And It can help the symptoms, but it will not take care of the problem. It will not take care of the problem. It can get you through until you're ready to do surgery. Now, in terms of surgery, there are two primary ways to do the surgery. One is what's called open, which is the traditional way, where we make an incision through your palm down to the transverse carpal ligament and literally cut the carpal ligament in the middle, and the surgery's done. We suture you up. And it's a great procedure. I can get it done in, depending on the thickness of the hand, probably about 48, sometimes 12 minutes. It's done under tourniquet so that the blood is not in the surgical site and we can see everything very well. I check out the nerve. I sometimes remove some of the tenosynovium from the flexor tendons, make sure everything looks good, close you up. And you don't come out in a splint, and you're moving immediately right after surgery. I am a fan of immediate motion for the most of my surgeries. Very important to keep those fingers moving, otherwise they will get stiff and cause more problems for you. And it actually promotes healing. The incision tends to be about 2.5 centimeters long in the palm. And the difficulty with that incision is that it tends to cause problems for a little while after the surgery, for a few months, when you put pressure on it, just from the scar forming. The other way that I do, which I do the majority of the time, is what's called endoscopic carpal tunnel release. And what it involves is this apparatus here. It has a handle, and it has this cannula that I stick into your carpal tunnel, and has a little blade that allows me to cut the transverse carpal ligament from the inside out, as opposed to going from outside in, as you saw on the prior slide. And the advantage of this is, one, there's actually less dissection. The incision is about 1 to 1.5 centimeters, not in the palm, but actually in your wrist crease. So I try to find the perfect spot in your wrist crease so that down the road, it's really hard to even tell that you have the incision. When you flex your wrist, it's going to be right in one of these creases. I make the incision, and then I use 3 instruments. One is literally a spatula to help clean off the underside of your ligament. And then we stick what are called dilators into the canal. And those dilators make a space for me to put the camera and the blade. You put the camera in. I take pictures of the ligament intact. This is a picture of the complete ligament intact from inside your body. This little clear layer on top is a little bit of the synovium that wasn't removed. And then on this side, this is a little blurry. If you look at this edge here, and what looks to be red here, this edge and this edge are the cut edges of your transverse carpal ligament. This here are the structures above, which is called palmar fascia, and there's even some muscle up there, which have not been cut. Should we have done the open procedure, we have to cut through this. And that increases more bleeding, potentially, and more to heal. However, doing it this way through the endoscopic, I cut the ligament, it's done. That's it. We pull out the camera, I put literally 2 sutures in, rarely 3, but sometimes 3 sutures into that little incision in your wrist crease. That's it. You come out in a bulky dressing, no splint. The dressing comes off in about 3 days. You see therapy 3 to 5 days after the surgery. They will take the dressing off for you, look at the incision, and start you on your therapy. Again, you're moving. I tell every patient when they come out of the operating room, you got to move your fingers. Move your fingers. You're not going to damage the procedure. You're only going to help, actually. So it's a fun procedure because it's great results. Patients have loved it because it's not right in your palm. There have been some studies showing that it can help patients return to work 2 weeks earlier. One, because they can put pressure on the hand more quickly. Long-term results of either the open procedure or the endoscopic procedure are equivalent. They both get excellent results in terms of the numbness and tingling healing or resolving. This is all done as an outpatient. You come in a couple hours before the surgery is scheduled. They get you all set up. I do it under sedation and with local anesthetic into your wrist area. I do an injection, but the injection occurs after you've already been very sedated. You rarely remember coming into the operating room. Some people do say some funny things, which I do bring up in the post-op visit, but it's always, patients are always delighted. And then what's nice about doing it under sedation with local anesthesia is that you get to go home pretty quickly after the surgery. It's once you're awake and alert and able to take care of things that you need to take of. And some people leave within a half hour of surgery. So our anesthesia team, we met and they are phenomenal. Again, it's another great team. And we all work together to make sure the patient is most comfortable and taken care of before, during, and after the surgery. Now, I allow patients to begin showering after the surgery around the 5th day. All wounds that we do incisions on tend to get enough what's called epithelialization, healing of the wound, around 3 to 5 days to allow for showering. I still do not like soaking in water, especially dirty water. But it's okay to shower and let the water run over it. Your sutures will be removed by the occupational therapist or by myself, but typically be removed by them. If they have any concerns on the incision, I will walk across the hallway and take a look because I'm right there. And regarding, again, therapy, they will progress. I trust them implicitly to progress exercises and activity as necessary. It's pretty routine. If they have any questions or concerns, again, they can pick up the phone, come across and talk to me. Either way, it's easily taken care of in terms of communication. We always promote with any incision scar massage because it helps, one, pain. It also helps the scar heal well so there's not a big lump where the incision was made. And the big lump is called keloid, which some people produce more keloid than others. But again, the scar massage will help anybody with their wound heal better and more pretty, really. And then you always will see me around 10 to 12 days after surgery. That appointment is often made when you schedule a surgery. So you will know often when you schedule the surgery, you will know when you will first see the therapist, that will be scheduled, and then your first visit with me after the surgery. Often after I see you, more often than not, I don't need to see you again. The first thing people say that, golly, I wish I would have done this sooner. I could have gotten more sleep. The first thing that most people will notice is that at night, you're not getting that numbness and tingling. That night, you will not have the numbness and tingling, more often than not. I'd say at least 8 out of 10 people come back saying that. The most that people complain of when they come back is residual numbness and tingling in the tips. Any nerve can heal about 1 centimeter a month. So often I'll show patients the distance is about 15 centimeters from where the carpal tunnel is compressing the median nerve out to the tips. And typically I will tell patients you can get improvement up to 18 months after the surgery. But frequently patients will come back saying, that night I slept like I haven't slept in years. And it's a delightful thing to hear, and it's delightful to see them with a big smile on their face and no bags on their eyes. If there is that decreased size of your thumb muscle, the thenar atrophy that I mentioned prior, we typically do not see that return. So we can't guarantee that that's going to get better. But it won't necessarily get worse because now that nerve is able to function better. That being said, I can still picture the gentleman that had a picture just like I had shown you with that thenar atrophy, and we told him, you're not going to get that back. Sure enough, being the surgeons that we think we know a lot, the patient came back, and golly, his thumb muscle was much improved. It had a much better contour. So no rhyme or reason, his body healed well, and fantastic for him, his grip got better. But again, there's no guarantee that that could come back. But it won't get worse.